All right, hey guys. Today we're gonna talk about lipedema and menopause 2.0. We've had our first session with Dr. Youssef about 7 weeks ago, and we had since then so many questions about hormones and the effect on lipedema, how to minimize it, prevent progression, what makes it worse, what makes it better. And getting all these questions, we're like, all right, let's have another session with him so we can get all these answered. Let me write your questions below. Doc, can you hear us? Awesome.
We are here.
I love it. How you
I'm
doing?
great. How are you?
I'm doing awesome. Thank you for joining us.
Oh, thank you for having me again. I was looking forward, and I'm really excited today. We're going to bring in new things, start from where we had left off last time and then see what we can add and see what questions people have for this time around.
You're like the most wanted person after that live. We got like patients calling us and like asking us like, hey, when are you gonna have another one for because they had so many questions about. I mean, you've hit on a point where most people have like truly no idea how to minimize, how to replace, what to do. They didn't know like all the stuff you mentioned before, PO, patch, pellets, this, what's the type, stuff that they take for granted. But I mean, that you opened a can of worms. So I have a list.
You know, something very important and nice happened since we last we're on live together. I just saw in the news today that there's a committee that physicians and journalists that were with the Senate today discussing menopause, basically mostly advocating for more time, more research, more money, more attention, because this is no longer the taboo. This is no longer the natural thing that women should just go through and basically suck it up and live with it. So this, I saw this in the news this morning, and it made me super happy, more even excited that we're talking about menopause today.
That's awesome. I mean, this is great to hear. Last time I was in Washington, D.C., I mean, they were, that's lobbying for everything, as you know. But like one common thing, like, lipedema doesn't exist, right?
Yeah.
Menopause, I mean, it's like stuff that's like normal for like, I mean, it's there. And this is awesome. And if the field is heading this way, I mean, that's crucial. I think that's going to help the lipedema patients a lot. It's going to help women a lot around that age a lot. It's going to have more guidance to it.
It's
This is
about
great.
time. It's about time. If we look at that research that has been done historically, I don't know the exact ratio per se, but the amount of diseases that affect men versus the amount of diseases that affect women, the attention that it gets is it's like almost 10-1. So it's insane. But we're so happy again. More and more of these things will raise awareness. I think also people should start advocating with their local representatives, because this is very important.
That's awesome. So you mentioned diseases. Do you look at menopause as a disease? How do you see it from your angle?
Well, I see it as a transition period that I, in the most recent years, that I try to educate my patients that although this is an expected event, it should not be kind of viewed as a normal, like a U-turn in your life. My goal is to extend your healthy years as long as I can, and keep you as healthy as possible and happy as possible, not just keep you living longer. Big difference between just keeping you living longer, struggling, and getting you optimized, happy, healthy, able to enjoy your daily routine, your going out with your friends, your sexual life with your partner. So that's what I've started educating my patients about. Sometimes I get resistance. Sometimes, I get a huge welcome when I start talking about it. That this should not be viewed as a, um, like a sort of like the beginning of the end. It should not be. It should be obviously a new stage whereby we're gonna do things. We're gonna optimize your health, tweak things around to get you to keep you as healthy as possible.
So basically, you elongated the quality of life
That is correct.
for people, which is awesome. Which is awesome. Well, we just got a question here from Maria from the Global Lipedema Awareness Group. And just kind of like a side note here, if you guys, you're not on any lipedema group, definitely go and join Global Lipedema Awareness Group. It's like one of the best groups in the world about lipedema. They talk about anything related to lipedema, surgeons, what to do, compression, all that stuff. And Maria is awesome. Her group is awesome. The people are awesome. Definitely go and join that group for sure. Anyhow, her question is, how many years does a menopause cycle last? And can lipedema return during this cycle?
Well, just to kind of clarify some definitions, and although I don't like to stick very much to definitions, but obviously it helps us kind of guide patients around. The average age of menopause is 51. That's in the United States. Obviously, give or take some years in different areas. But in the United States, the average age is 51. And by definition, menopause is no menstrual cycles for 1 year. But the changes, the decline start happening way, way before that, almost a decade before that. We're talking about almost 8 years when the changes start happening, which that phase we call perimenopause, which is a very confusing phase to everyone. Doctors, the patients, everybody gets confused with this stage because really nobody knows what to do or nobody knew what to do during those years. And the struggle starts. I see it sometimes in what we call the late reproductive years into perimenopause, into menopause. Now, after the onset of menopause, 51, if nothing has been done, if no intervention, if no hormone replacement has been done, the decline will continue to be gradual. Now, we get to the point where the decline is not that steep because there won't be enough follicles in the ovaries. The ovaries will not be, producing that much towards the end. The decline is not that steep, but the effects on the organs will continue to gradually decline. And we're talking about head to toe, as we spoke last time. We're talking about brain, we're talking about oral cavity, skin, heart disease, gut, vaginal dryness, bone health. I mean, just about everything.
That's awesome. So, if I understood correctly, it's about an 8-year process before menopause that starts. Average age is 51, and let's say if somebody doesn't do anything for that, and it starts, let's say 51. If we're gonna talk math, it started around the age of like 43, and kind of the amount of hormones gonna go down. No replacement. They hit 51. Nothing's being produced, and it's gonna go down a slippery slope, basically.
Correct.
So the replacement would start in their 40s?
You can start replacement in their 40s. Not everybody. So that's the tricky phase between the perimenopause and the menopause is the tricky phase on what to replace with, how to replace, because this is the area where, everybody has very specific needs. Sometimes people don't need a whole lot of estradiol. They might need some progesterone. They might need some testosterone, and they might need some natural substances that look like estradiol that can help alleviate the symptoms until we are nearing menopause where somebody really truly needs fully estradiol, giving them either by, patches or pills if we do, or pellets or creams, whatever the route we decide to do.
And that's where the expertise come into play. because like you want to keep that balance and you want to see how much that patient is lacking from a whole estradiol basically, and then you kind of compensate the difference.
Right.
And as
Right.
time goes by, they're probably gonna need more until they hit that 51 plus or minus, depending on that, and then you need kind of full dose basically.
Yes. Yeah. Absolutely. Absolutely. Obviously, there will be no one size fits all approach because there are no two women that are the same. You know, some people start feeling the symptoms a lot earlier, some of them a little later. So that would depend. And that's why the perimenopause is a bit of a tricky area. People disliked it because of this.
Of course, of course. The other part of Maria's question is, can lipedema return during this cycle or perimenopausal area? Let's say, and if I understand correctly, kind of let's say you have lipedema, whether you treat it, get liposuction or not, or kind of like you get to that phase, can that perimenopausal hormonal change advance lipedema or return lipedema?
We do know that lipedema in general does get worse around perimenopause to menopause, and this is due to a lot of reasons that we've discussed last time, be it the drop in estradiol and the effects on all the metabolism, also the changes in the estrogen receptors, the ratio of the receptors. So yeah, it can return. It can return. Um, it will pretty much depend on the prior treatment, how much has it been, if there's any residual disease. I don't know if in your case, you've had somebody who've had adequate excision and come back after menopause with recurrence.
Yeah. Yeah, that's a great point. We haven't had anyone who kind of recurs, but I'm sure it's a numbers game. But you mentioned something that's crucial. I think if the treatment was done well, you cannot take, it's not like curable. Liposuction is not curable. It's not like appendicitis, you take it out, they don't have it anymore. So you're kind of like minimizing the amount of fat cells the patient have, like significantly, right? So let's say you go to 100 from 100% to 10%, right? So you have 10% residual, so they gotta maintain healthy lifestyle, diet, exercise, all that stuff. And now adding to it is the hormonal replacement. Because even me, I never thought about it. I was like, you know what? Are you doing diet, exercise, all that stuff? And I never even talked about peri. And most of our patients are kind of 40 to 65 years old. That's our population. So I'm like, now I'm learning a lot because I'm like, now I don't just say, hey, make sure you maintain it. I should make sure you get your hormones replaced well.
Yeah.
Because even if she did the right thing, she might still have hormonal changes and advancement in her residual. Or let's say if she treated the legs, she didn't treat the arms might advance, right? Because the arms were not treated. And then basically from a prevention standpoint, then that's crucial part of the treatment, in addition to LippyLipo, liposuction, all that stuff that they would do.
Yeah. Also, something that's very important that we cannot disregard, also the effect of estrogen on vasculature, including the lymphatic system. So with the decline of estrogen, there's also some dysfunction, or the blood vessels don't function as they are. And the lipedema, that can be also a crucial thing, because that can potentially worsen the disease from the lymphatic standpoint. So that's something that people should be aware of how estradiol works and how it affects the cardiovascular system, including the lymphatic system.
Makes sense. And one of the questions we have here is basically in that cycle or perimenopausal area, we have hormonal changes, correct? Then the next
Absolutely.
then the next question is, after 51 or after kind of like, we don't have much residual, are there still hormonal changes after the fact? Or basically that's none. Basically that's how it's going to be.
No, there definitely will be some hormonal changes, but they are less pronounced. They're not going to be as exaggerated, because the steep decline had already happened when we hit, you hit that 1 year after menopause. That steep decline had already happened. The decline after that becomes much of a lesser slope, you would say, because there's not a lot of residual function, not a whole lot of residual follicles in the ovaries to produce that much estrogen.
Makes sense. At what stage of that 8-year cycle the most change or the most decline happens?
It's hard to tell, but if you were to kind of see it by the symptoms, it will be the last 3 years before menopause, 2 to 3 years before menopause. That would be the most prominent findings, or the most prominent decline. The last 2 years before the age of menopause into right menopause.
So basically, it's like slowly trending down and then it crashes.
Crashes and then it goes back slowly again.
And then slowly back down. So
Yeah,
slow down, crashes, and then kind of continues back down.
yeah.
That's awesome. I mean, this is awesome information. That's great. Okay, let's take some questions here. Great questions, Maria. From M2A81, she's kind of like saying, good evening. Does pregnancy occur during menopause? And I thought kind of like that's, outside the lipedema, but since you're here, I'll just, we can
I mean,
get to some value.
if somebody has already had menopause, pregnancy is almost impossible. You might have this, 1 in a million, 1 in a 2 million person who has still like a follicle that ovulates, and then if everything lines up. But yeah, we're talking about almost impossible. Can it happen with in vitro? Yeah, it can happen with in vitro, but it cannot happen naturally.
Awesome. Another question here from Lydia is asking, my diagnosis is lymphedema. Is there a surgery for this? And I guess I'll answer that. So you've got lipedema and lymphedema. Now, stage 4 lipedema becomes lipedema with lymphedema. And the treatment for that, we still do LippyLipo for that. However, if you have like one leg lymphedema, kind of the etiology is different, didn't start with lipedema, usually there are two options. One is a bypass, lymphatico-venous bypass. Basically, they see where the obstruction is, and then they take that lymphatic vessel, which is like so tiny, like as tiny as the hair, and then they plug it into a vein so the return is better. Or they will do liposuction for that if they cannot identify that treatment. So it depends on what you have, and without knowing what you have, it's very difficult to recommend. But I tell you, either liposuction or if you have lymphedema by itself, or liposuction plus lymphatico-venous bypass. Maria saying thank you very much. You're welcome, Maria. Again, shout out, guys. Go to her group. It's awesome. It's probably one of the largest out there, and she's one of the beginners of raising awareness for lipedema. And I learned a lot from her in terms of, especially when I started, kind of like the treatment in terms of compression and afterwards. And I mean, she just like the knowledge is huge. So definitely check her out, guys. Global Lipedema Awareness Group. Another question we have here is, Vli is asking, are there studies regarding lipedema being a factor for osteoarthritis? I have had this since I was 40, and now it's grade 4. I assume it's stage 4, and exercise normally, never too much impact on the knees. So I guess the question, any relationship between lipedema and osteoarthritis from your standpoint?
I don't know if there's like a direct relationship. I mean, we know osteoarthritis is something that happens with age. If somebody has worsening lipedema and they have more fat deposition in their lower extremities, that can potentially make it worse. But that's all I can think of, to be honest. I don't know if you have anything to add there, Dr.
Sure.
Salameh.
So that's helpful. I mean, because from a hormonal, you're saying that's not much from a hormonal relationship to osteoarthritis, which is good. I didn't know that answer. And maybe there is. And I think that's kind of like you're part of the question.
The hormonal aspect that that could affect bone is the decline of estrogen, but osteoarthritis per se, not but in general, bone health gets affected with menopause. You're having less bone density. Could that worsen an already existing osteoarthritis? Very possible, but osteoarthritis we know as a isolated problem. It's a problem with age where the joints are getting damaged by overuse and friction, and etc.
Sure, and that answers the question. From a lipedema standpoint, what we found is what happens, unfortunately, with most lipedema patients, a lot of the weight, lipedema, it's heavy by itself, and most patients have falsely elevated BMI, not because they are fat, because, I mean, when we take that fat out, it's a heavy fat compared to regular fat. So the weight of the lipedema fat, and it sits all the way around 360 degrees around the thighs, 360 degrees around the knee, and 360 degrees around the calves and ankles. So first, the mobility of the knee gets affected. Because of the fullness on the inner knees, patients start to get that, we call it valgus deformity. Basically, the legs are down, and the thighs are down, and then the knees, they start to separate. They're kind of touching, and then the foot kind of starts separates to the outside. And that by itself causes abnormality on the dynamics of the joint, and that causes some more wear and tear on the knee itself. To make things worse, because of the heavy weight of the lipedema, it's more wear and tear on the knees. And people go into a vicious cycle. Because there's more wear and tear and there's more heaviness, people are not as active.
Yeah.
And they're not more as active, they put on more weight. And it all happens around perimenopause. Now you talk low, especially they don't have hormonal replacement, low metabolic rate, they're gonna gain weight, they're not as active, lipedema is getting worse. I mean, you add all these up together, the joints are getting worse, they're having pain from that, and then they advance from stage 3 to stage 4. Most of these patients, unfortunately, end up with knee replacement because they think, that's the problem. It is the problem, but that's a symptom of a disease. The disease is not fixing lipedema, not fixing the hormones, all that stuff. So they go from one knee to another knee to another knee without anyone fixing that problem, which is take care of the lipedema, take care of the hormones, keep things at bay. And that's it's the band-aid is the knee replacement. The real problem is get your hormones right and get your lipedema right. And that's what usually causes osteoarthritis for these patients.
Yeah, it's like a snowball effect, just basically go into.
Yep, absolutely. I'm too saying thank you so much for the information. You're welcome. We love it. You can tell we're very passionate about it. A lot of thank yous here. Saz was saying, I love your work. You're amazing. I just wish you would come to Wisconsin. Thank you. I think she's talking to you, Dr. Youssef.
Thank you.
So Brandy is asking here, how do you ensure the lymphatic system does get damaged during surgery? I think she means does not get damaged during surgery. And that's an amazing question, Brandy. The key with lipedema surgery is experience. Like anything else in life, you have to go to the person who does only one thing, who's the best in the world at doing it, and they have consistent results. And the numbers, you got to look at the numbers. And basically, another way to reward that, and I'll answer your question in a second about the technicality, is like, hey, out of the 100 cases you've done, how many of them developed lymphedema afterwards, right? So, and you want that number, there's nothing zero in life. I mean, knock on wood, we haven't had anyone who developed it, but it's a numbers game, right? So you got to make sure the numbers of that surgeon is less than 1% for that entity. Some surgeries have 5% risk of this and that, kind of depending on, and that's kind of like, because it's truly a numbers game. So, and now let's say, okay, well, that number is less than 1%. Now the next question is, what do you do during surgery to minimize that? And I'm going to give you an extreme example. Few months ago, I got a call, somebody reached out to Insta, all that, long story short, a plastic surgeon out of Turkey, okay? And they do something, he was asking me my opinion about dry liposuction. If you had to guess that, Dr. Youssef, what would you think dry liposuction is?
I mean, if I were to bloodless, I don't know.
Pretty
Or
much. So I was like, help me understand. You're doing dry liposuction. First, I haven't heard of it. I mean, there's wet, there's super wet, there's this, that. I was like, so how are you doing it? Like, what's that? Because he was calling me for his complications. And I'm trying to understand what he's doing wrong so that I can help him. So what they do is they put a tourniquet on the thigh, as if like you're doing like orthopedic surgery, right? They totally obstruct the flow, right? So obviously patients intubated, general anesthesia, they give them IV heparin to basically so that they don't occlude their entire extremities. I mean, look at how invasive that is. They occlude, they put a tourniquet, they occlude the lower extremity. There's no blood, no blood supply, no arterial inflow, no venous backflow. And then they do liposuction to be able to kind of get the stuff out. The problem with that is when you do that, many things happen. One, the risk of the surgery goes significantly high. Second thing, risk of DVT, PE, all that stuff goes significantly high. Then risk of bleeding because they're giving them thrombolytics and heparin, all that stuff to kind of so that they don't clot the entire lower extremity. So now they took that problem to that. The other thing that he wasn't thinking about, and I was thinking about as he was asking me, which ties back to this question, is the lymphatics. When you go on a dry field, the space between the lymphatics, the lipedema fat, and the skin is so compressed. So with any cannula entry and exit, not only you're sucking out fat, you're damaging the lymphatics because there's no separation, right? Like, in the surgical field, you want different planes. Well, that's a good plane to be for this thing, and that's a plane for that thing, and so when they do that, they're damaging the lymphatics, and they did it so that they don't have blood loss. Yeah, you're not going to have blood loss because there's no blood coming to the leg. But the downside, they had like damaging lymphatics, they had the risk of surgery, contour irregularities, all that stuff. So crazy. It's crazy what people do. Long story short, I told that guy, don't call me again. I don't want to be in any relationship just from the medical legal standpoint because, I knew something bad is going to happen, right? I mean, you just know it. You just want to totally isolate yourself. And that's what I did. But to help the patients here on the call, the key with not damaging the lymphatics is good tumescent. You gotta make sure the area is nicely tumesced, you have a good separation. This is probably the most, like many things in life, there's multiple things that really make a difference. 80-20 rule, 80% of minimizing the damage in the lymphatics is good tumescent. Making sure the area is not dry, you have good separation. Then, lesson to that, which is also important, the type of cannulas, the area that you're lipoing, which anatomy you're doing. Are you close to the lymphatics? Are you separated? If you're lipoing in an area where you are close to the lymphatics, you want to make sure you're using very tiny cannula, you want to make sure you're using a curved cannula, and you want to make sure you're above that plane. And it's so tumesced that the lipedema fat is sitting much higher than where the lymphatics are. And when you do all that stuff, your chances of having lymphatic damage is very, very low. Is it 0%? No, that's nothing 0% in medicine, but you're getting it to like as low as possible.
That's
So
awesome.
that's your answer.
I,
I mean, you're the surgeon.
I,
What's your thoughts on that? I know you do a
I,
lot of hormones, but you're the surgeon as well. What's your thoughts on that?
I cannot agree more. And I see a little bit I can see your frustration a little bit from the conversation that had happened. It's all about finding the right technique, as you had explained to the patients. There's absolutely nothing in medicine that there's zero complication. If you have zero complications, obviously you're not doing enough. But you have to have a very low complication rate, and you have to know your anatomy. You've done enough, and you have to be so passionate about what you're doing, just as you are. And I think that combination would get you the lowest possible complication rate ever.
Absolutely.
Yeah.
Absolutely. And to be fair to the other people, like when people go into a challenging procedures, that's a very steep learning curve. So they were having very high transfusion rate, right? Because lipedema fat is very bloody, and if people don't know what they're doing, their transfusion rate can be 15-20%. And we've seen that in some centers, they're kind of overseas. And probably to minimize that number, they were having a lot of people going to the ICU, transfusions, all that stuff. To minimize that number, they're like, you know what? Why don't we just put a tourniquet on? And now our transfusion rate is going to be 0 because we're not losing any blood.
Yeah.
Right? That's kind of how they got that. But they didn't think through that
Yeah.
what's the side effects of doing that? And that's when they went into all these problems that they were having, and they lost track on what's the right thing to do. And that's when they
But
started treating
that,
her.
that's pretty much like, instead of treating the root cause, they patch the problem. Instead of optimizing their technique, they just block the blood supply. I mean, if somebody has no blood, they won't bleed, right? So
Absolutely. Absolutely. Okay, so let's move on to another question here from Autumn. She's asking, what testing is used to diagnose lymphedema? So I guess I'll take that. So there's two entities, lipedema, lymphedema. Lipedema, it's a clinical diagnosis. It's based on your symptoms, bruising, heaviness, swelling, the shape of the legs, runs in families, kind of all that stuff, three-trunk appearance. Lymphedema, it's a problem with the lymphatics. It's a lymph node problem. It's a lymphatic problem. Sometimes you get the dye studies, ICGs, they kind of inject it and see where it's going. It's two different entities. And the life today, our expertise is lipedema, kind of like lipedema, how to treat it and that. Now, that being said, stage 4 lipedema becomes lymphedema because the lipedema fat becomes, you have so much fibrosis and scar tissue that it obstructs the lymphatics, and then the lymphatics doesn't go back up. And that being said, like we say stage 4 lipedema, lymphedema, but sometimes I see people with even stage 2 or stage 3, they have lymphedema. They have like swelling of the foot, which we normally don't see with lipedema. So even though like we stage them and we type them, it's such a wide spectrum where you can have lymphedema probably at stage 1, 2. Some people might have it. Some people might have it at stage 2. Some people might have a combination. But if you have like one leg lymphedema, this is true lymphedema. But if you have lipedema and some element of lymphedema with it, most likely you have both. And probably lipedema resulted in lymphedema. And that takes us to early treatment, early intervention, hormonal treatment, like anything you can do to minimize that. Anything you have to add here from a prevention standpoint?
I mean, the two things that you had mentioned. Obviously, I would like a little bit later to tackle a few points and how people should optimize their transition, not just with hormones and not just with surgery. But if you want to take the questions now and then we jump into it.
No, actually, go ahead. Go ahead. Let's.
So, you know, the two big things in lipedema is that it's resistance to exercise and diet. But I don't want people to start taking that and thinking that they should not exercise and they should not diet, because the transition into menopause slows everything. And the effects on menopause on the entire overall health are really almost like steep changes, that the risk of heart disease becomes similar to that of men when women get to menopause. So exercise should remain one of their top priorities, and it should still include resistance exercise and weight bearing exercise. And by that I mean build muscle, strengthen your muscles, and strengthen your bones, because both components, they weaken into menopause and after menopause, and they become a major risk factor for health problems later on, whether it's fractures, whether it's falls. If you look at people who certain populations who don't use chairs as much as we do, who sit mostly on the floor, the elderly people in that population fare way better than our elderly, just because their lower extremities are much, much stronger than ours, because they tend to use them more often, sitting on the floor and standing up. So not telling people to, stop using chairs, but obviously think about that. Think about that when you want to go to the gym. Think about that, how you stand up from a seating position, et cetera, et cetera. So exercise should remain a mainstay. Nutrition, although diet won't do crazy things for lipedema, but nutrition should be important. And people in menopause require they have different nutritional requirements than pre-menopause. They need more protein, so they should make sure that they're getting an adequate amount of protein. The amount of protein that they need is about 1.6 grams per kilogram of body weight. So that's something extremely, extremely important. Dietary habits, not necessarily just the quantity, but the habits, how they eat, when they eat. um, if somebody is deciding to do fasting, it's better not to be fasting and do strenuous exercise in the morning. So if somebody elects to do any kind of exercise in the morning, they should have some kind of calories in, at least some protein if they don't have a full meal, some amino acids to get them through, because the immediate reserves in women that are needed to kind of supply the immediate sugar are much less than men. So they cannot do exercise when they're fasting. So that's something kind of important. Obviously, when we go in and we talk about nutrients and micronutrients, stuff like calcium is extremely, or calcium dense foods, magnesium, all these things are important. And then I want to transition into gut health, the gut microbiome and the microbiome in general, because something very important happens in menopause is that the microbiome of women become very similar to the microbiome of men. And that's because of the change in estrogen. There's a whole shift of so actually something called estrobolome in people, where there's a colony of bacteria that resides in the gut that helps with the metabolism of estrogen, how it clears estrogen, how it recycles estrogen back into the circulation. So that all changes in menopause. So also the right probiotic has to be chosen. The proper food for the probiotics, prebiotics, have to be properly chosen. I tell this to all my patients, and even myself, I practice it every day. I make sure I get a good chunk, varied or a variety of sources of prebiotics, whether it's fermented foods, high grade yogurt, small amount, sauerkraut, prebiotics that are the proper food for the gut microbiome. A good supplement that I recommend for a lot of my menopausal patients is creatine. Creatine is a very, very important supplement for, we used to think about it as a supplement for bodybuilders, but it's beneficial for everyone. Beneficial for memory, beneficial for cognition, beneficial for muscle. So little things that people should optimize into their menopause that, I think that you would agree that even their surgical outcomes would be better.
Absolutely. I mean, that's a totally different angle that you're looking at, which is in a way it's like the future of what we do in medicine, but it's actually you guys are doing it right now, which is awesome. I want to go back to the point of like starvation, intermittent fasting. There's a lot of our patients who do either keto diet or intermittent fasting, and what's your thoughts on that? And I want to kind of link back to the lipedema, because a lot of in our community will say, okay, low sugar, anti-inflammatory. A lot of our patients are doing keto. A lot of patients are doing like intermittent fasting. That kind of like that. You kind of see those terms very frequent. What's your thoughts on that? Are they hurting themselves by doing that? Are they helping themselves? What's the pros and cons of each?
So there's no one diet that's gonna fit everybody. So there is a diet for everyone. I say that someone should always choose the diet that works best for them. Don't restrict yourself based on some random recommendations. Obviously, there are certain diets that would fit the majority of people. I'm looking at a well-balanced anti-inflammatory diet. Okay. The very restrictive keto diets, although they can work in the short term, they might have issues in the long term in terms of compliance and in terms of potentially running into almost like an eating disorder. I see it. Now, if somebody wants to do intermittent fasting, that's totally fine, as long as they're paying attention into their requirements if they want to work out while they're fasting. So that's important.
Sorry to interrupt. What's the downside of that? And the reason I'm asking is I do see that in our patients where they do intermittent fasting, and then they kind of like they do a workout in the morning. And from what I'm understanding, that can potentially impact their health if they do it this way. Can you just elaborate more on that
Yeah.
point?
To put simple, when you work out, you need energy, and the energy in the morning when you're fasting is not going to come from the sugar that's floating in your blood because your brain has used it overnight. It's going to come from the storage. The first storage is your liver, which is the glycogen. Women do not have a high glycogen storage compared to men. So there's not enough reserve to do a workout in the morning. So they tend to go into almost like it's like a counterproductive, non-anabolic state. You know, the benefits of the exercise might actually be dampened if you don't have enough reserves. If you want to do some fasting or fasted workout.
That's interesting. Uh, what would the impact be on lipedema from your standpoint if they do that? Do you think that's hurting them? It's causing potentially more stress on the body and potentially making it worse, or it doesn't matter?
I'm not sure. It's a very interesting question. You know, obviously you could burn some fats, but are you burning the lipedema fats? Big question. I don't know. Probably not. But are you also stressing yourself, raising your cortisol more than it should be? Could that cause a kind of chronic low-grade inflammation that can worsen things? So two important points that should be put hand in hand to see where
Yeah.
we're heading, you know?
And that's another, I mean, this is awesome. I love this discussion because that's why it makes lipedema even more complicating. Yes, I mean, doing intermittent fasting, yes, we're working out in the morning, and probably they're losing the regular fat, but at the same time, they're probably making the lipedema fat advance more. And people are like, you know what, I'm not seeing any outcome, even though I'm doing all this crazy stuff. They're probably seeing the outcome on the regular fat, but the lipedema is getting worse. So from the outside or from a scale standpoint, there's not much movement. They're actually hurting themselves on the other end. This is awesome.
Yeah, I mean, if somebody's doing intermittent fasting and they're not doing fasted workout, that could be okay. A more sustainable approach to intermittent fasting would be, you know, like a 5-2 approach or a 4-3 approach, whereby you 4 days out of the week you eat your breakfast and then 3 days you do proper fasting, where you do that 17, 18 hours of fasting. You know, get the benefits of fasting, whether you're actually looking into some weight loss, but also some effects with the autophagy that comes along with fasting, cleaning out all these bad cells, bad toxins in your body. So that would be one way of approaching fasting that I kind of throw it out there for people that like the idea of fasting.
I love it. I love that. Let's take some questions, and um, I could see we have many coming. From Helen, she's asking if lipedema gets worse with my first pregnancy, but I plan to get pregnant in the future again. Should you get treated with lipedema with LippyLipo before your next pregnancy or after? I'll take that question. If your lipedema got worse with your first pregnancy, do LippyLipo in between. Because the odds are it's going to get worse with your second pregnancy, and it's going to get worse with menopause. And if you don't do hormonal replacement, it's going to get even more worse. The problem is with advancing lipedema, it stretches the skin. The more skin stretches, the less the cosmetic outcome you're going to need, and the more amount of surgeries you're going to need to get to your final outcome. Early treatment is key. So if that was a family member, treat lipedema first. I mean, you knew already it got worse with your first pregnancy, get it out. The more prevention you can do, the better. First, you will save on the long run because instead of needing 1 or 2 procedures, you probably need 3 or 4 if you let it advance. Second, stage 4 lipedema or stage 3 lipedema, when you take all that lipedema fat, you're going to have great infrastructure, but you're going to have extra skin, and then you're going to end up needing skin resection. So not only you save on the amount of procedure you're going to need from a liposuction standpoint, but you're going to save on the skin resection part, and that's a bigger surgery, more risk, scarring, all that stuff. My advice: do it first. Don't let it advance.
That's awesome. I mean, I was gonna say, I was gonna see what you're gonna say about that. it makes total sense. I think people worry about surgery after delivery. So you can probably kind of reassure them about, technique, recovery, so that those doubts are out of their head, and also that doubt comes out of the head of a lot of obstetricians, because a lot of people would tell patients, get done with all your pregnancy and do your cosmetic surgeries later. So that we should delineate that as well.
That's awesome. Great point. Renee is asking here, do either of you know a specialist that could diagnose me in Washington State? My BMI is 21, but my knees and calves and ankles don't change. I need surgery, but I have no diagnosis. I feel I'm stage 3. I'll take that. You don't need diagnosis for LippyLipo. Lipedema is a clinical diagnosis. Basically, if you have the symptoms, if you have the looks, you just don't need it. What you need to do is you do your homework and make sure you have a good hormonal replacement specialist and you have a good surgeon to treat your lipedema. You don't go down the rabbit hole of, oh, I need diagnosis first, and then they take you to do this and that. There's really no need. I mean, it's good to know. Most patients who have lipedema, they're gonna know it. And I'll tell you kind of like in a box here, the things you look for. It runs in families. No matter what you do, it's resistant diet and exercise, 3-trunk appearance of the leg, easy bruising, swelling, coughing, all that stuff that you see typical with lipedema. And if you have any questions, send us your pictures. We'll take a look at it. I go live on Mondays. And if you want to send it to me, I can put your pictures up and we can kind of go over the things of why we think it's more lipedema or not and kind of help other people. So we add value. Anything you want to add here, Doc, before I move to the other question?
No.
Isabel is asking who I should talk to get hormone testing done and get a good analysis of the result. My GP doesn't want to do the test. I'll give that to you.
And just find a gynecologist that does menopause. Unfortunately, when we put up our privileges on websites and stuff, because everybody trained in menopause, whether it's 1 week or whether it's 2 years, we check off menopause as, an area of expertise. So choose somebody who treats menopause, tests for menopause, but also do your own research a little bit and see what's out there, because some people still treat menopause the way we did 25 years ago.
I can so relate to you on that point. Like, we see it on the other end. We see it there. Patients are calling, it's like, oh my God, my plastic surgeon told me that you should never get your ankles liposuctioned. You should never get your calf or liposuction below the knees because it's like high risk and the danger and all that stuff. And you just should never touch it. And in a way, they're right. It's an expertise, right? But when people tell you, I don't do it or you shouldn't do it, it doesn't mean it cannot be done, or it doesn't mean like those analyses shouldn't be done. All what that means that they are not able to do it. Do your homework, do your research, and go for the people that have an answer to your question. Because even if they are a specialist, they might be specialists in other areas, not in the area what your question is.
I agree, 100%.
All right, let's keep on going here. Dr. Bitar, greetings from Washington, D.C. to my dear friend and amazing surgeon, Dr. Salameh. Big shout out, Dr. Bitar. Thank you for joining us. He's awesome. Anyone in the D.C. area, definitely check him out. Nadine here is saying, I love it. Thank you so much for your advice, doctors. You're awesome, Nadine. Big shout out to you. Thank you for joining us. Brandy is asking, I've been hearing a heat deal about BP 157 and its benefits to aiding healing. Do you have any thoughts or opinions about using this peptide post-procedure? I'm going to get
this is completely new to me.
I actually, you haven't heard of it?
No.
Okay. Me neither.
Happy to research the topic and come back with a reel on it, but I don't know. I'm not gonna answer now.
Awesome. Actually, that would be great, because that's one of the things, right? So maybe Brandy here knows about something that we don't know about. Maybe it's something that really works very well, or maybe it's another gimmick that's out there. And that's a perfect example where if we don't know, we're gonna say it. We have no idea. We're gonna look it up and then see. And this is crucial. This is awesome. So yeah, Brandy, I'm not familiar with this peptide. I mean, I know you know a lot, Doc, about GLP-1 agonists. You know, it's kind of like a different game changer for many things, but not BP 157.
Yeah.
Okay. So Marge is asking, can you minimize the look of lipedema with cool sculpting with minimal lipedema noted to bilateral thighs? I'll take that one, and I don't want to like talk in specific for cool sculpting. That I'm gonna put it all under the non-invasive kind of devices out there, and I'll tell you my experience from our own patients. The problem with non-invasive fat treatment for patients who have lipedema, it almost always make it worse. And the reason for that is the heat, whether it's heat or whether it's cool, or you know, depending on the, it actually causes the opposite effect in patients with lipedema. It causes inflammation, and that's kind of how they kill the fat. Like they put too much cold on the fat, and regular fat usually dies. In lipedema, it's the opposite. The lipedema fat cells, they get angrier, and people sometimes we get what we call, and it's a well-known entity in that field, is PAH, paradoxical adipose hyperplasia, meaning you make the adipose cells, they got actually worse. Now people don't know about it, but I've seen so many people who have PAH who are actually lipedema patients, and now I'm like reconnecting the dots backward. I'm like, probably that PAH are actually patients who were misdiagnosed patients who had lipedema, who had non-invasive treatment done, and now they have worsened lipedema, and now they're coming to us after their failed treatment or the treatment that we don't know why it made it worse. We actually know why. It's lipedema that was traumatized by inflammation or not different than hormonal replacement. And that's what usually happens. So I would be extremely careful because these cases are one of the toughest to treat, because if you get PAH after those non-invasive treatment, it's like going through cement. I mean, the cannula, it makes it so hard, contour irregularities, scar tissue fibrosis. I would be extremely careful with those treatments, especially if you have lipedema. Don't ask me how I know, because I've treated many patients like that, and it makes it hard on the patient, makes it hard on me, and it's just like I wouldn't recommend it. I am Lati saying I need your services. Thank you. She's asking where you guys located. Doc here, he's located in Miami. I'm in 1 hour north of Nashville Airport, and we do different things. I do LippyLipo for lipedema. He does hormonal replacement, and among many other things, but he's the man. Marsh is asking, I hopped on late. Have you discussed any correlation with IUD, OCPS, and lipedema? That's a good question.
So the OCPs, we know that OCPs, what we're talking about, oral contraceptive pills. If we're talking about the combined oral contraceptive pills, the kinds that have ethylene estradiol, they do have an effect, negative effect on lipid metabolism, and anything that has negative effect on lipid metabolism can potentially worsen lipedema. I don't know the extent of the effect is, but the risk is there. Regarding IUDs, the intrauterine device, depending on what type we're using, if we're looking at the non-hormonal, it should have no effect. If we're looking at the progesterone, the progestin IUDs, although they're local, the higher dose ones might have a little bit of effect. We call it systemic effect over the body, and that might lead to a little bit of water retention, but the effect on lipid metabolism may be negligible if it's there.
That's awesome, and it makes sense. A lot of thank yous. A lot of people kind of like, they love the education, they love the information you're providing. And some people are asking if we're gonna save the life. They needed to kind of like yes, we will save it. That being said, sometimes we've had issues, like if the live goes too long, Instagram might not save it for us, but we'll try to save it for you guys. Brandy is saying here, I started taking liposomal creatine when I started menopause. I can confirm it is highly beneficial. And I think that's kind of when you were talking about the creatine effect. And there were like few conversations that I could read from people here saying that, yes, it's helpful and that. Because again, that's a misconception out there that, creatine is going to make you fat and, become so bulky and that. And like many things, there's a lot of things out there. Okay, there's a lot of comments and stuff. I'm gonna try to skip on some of the stuff just to go to like the key point questions here. A lot of insightful. Thank you. Plau is saying, I've noticed I get more inflammation in my legs if I work out fasting, I guess, early morning. Much better with a fed workout for me. I guess she's referring when you were talking about women having no reserve. Collagen, kind of like sugar reserve, like men do. Then he's saying, how can I get diagnosis and find a specialist? We'll save the slide. We discussed that in a previous question. I'm trying to get as many high quality AEK72 saying completely agree. 3 kids and surgically induced menopause at 29, almost 52 now, and wish this knowledge had been available years ago. What would you say for that? I mean, this is coming from, I can tell, from the bottom of someone's heart here.
Yeah, this is this hurts a little bit. It's never too late to be on hormone replacement. So that's something kind of important. If somebody's struggled for so many years, shouldn't continue to struggle. But if somebody has had surgical menopause, and if they have no contraindications to hormone replacement, should be on hormone replacement the next day.
So you think even if somebody like later, like let's say somebody is like 60 years old, they haven't met somebody like you, right? So it's okay to start it at that point. There's no like harm.
Yes, we used to say it's not. The problem in the past used to be with the types of hormone replacement that people were getting, and we discussed that in the previous slide. As long as we're getting estradiol, which is the native estrogen that we had in our body, people will be fine.
That's awesome. Autumn is saying, I'm outside Houston and I can't find an OBGYN that helps or listen to women over 40. They are more focused on delivering babies.
Unfortunately, that's the reality in so many places. I mean, I do half OB and half GYN, and I still deliver a lot of babies. But that should not take away from the other half, because I do feel strongly about menopause and hormonal imbalances, and I want to treat that. I'm sure there will be doctors that there must be doctors that do menopause treatment, and luckily now more and more are becoming aware of this. More and more are starting to like raise awareness and feel the need for this. So keep looking. You will find somebody who's going to take care of your menopause.
That's awesome. Another question here saying, I've done the biopellets over 6 times, not much, only increase in my sex drive, high testosterone. What kind of hormone replacement do you recommend? And do you use compound pharmacy / creams?
Yeah. So one of the types that I do is I do bioidentical pellets. We also do transdermal patches, creams, testosterone creams, whatever fits the profile of the patient, also whatever fits her prior experience and her preference. We have different options. There are certain deliveries that are more convenient for the patient, but obviously, as long as somebody's getting something, that's the answer. Somebody should be getting something somehow.
Yeah, that's awesome. And again, guys, like the aim of our life here is to raise awareness and kind of like to provide you with as much knowledge as we can. we would love to see everyone, right? I mean, we're very, very busy physicians, but at the same time, we want to kind of raise enough knowledge that you can go to your physician and you know exactly what you're looking for. You know what's out there, you know what are the things, so that we can give you as much knowledge as possible. Because I do see like a lot of, like I see here the question, or they come from KFUN 2015. I want to come see you from Texas. I've been listening to you for months now. I'm 53, had a hysterectomy with oophorectomy 2 years ago, and can tell it's getting worse. Thank you for your explanation. Now, thank you. Let me ask you a question here. That's a great point she's mentioning. Do you foresee, like, so we see like GYN surgery, it can be oophorectomy or hysterectomy or a combination. From a hormonal change, like from a hysterectomy standpoint, is there much difference? Does it add, does it not? Like, what's your thoughts on that?
So removing only the uterus with
Yeah,
ovarian, leaving the ovaries
like
behind.
hysterectomy, can hysterectomy by itself make lipedema potentially worse or change hormonal? Could that happen?
So if we're removing the ovaries, you're putting somebody in surgical menopause. The answer is yes.
100%.
If we are removing the uterus and we're leaving the ovaries behind, some of the blood flow to the ovaries still come. Of course, the ovaries have their own blood supply, but some of that blood supply comes from the connection to the uterus. Some, okay, especially if somebody's tubes are being removed. Okay, and we do remove tubes as a prevention for ovarian cancer in the future. Now, this intervention will reduce the blood flow to the ovaries. Although they still have their own blood flow, they will still have some reduction of the blood flow to the ovaries. And anytime you restrict blood flow to something, you will be decreasing the function. So the answer is potentially yes. If somebody has hysterectomy without removing the ovaries, the answer is yes. Most likely, yes. There will be a fluctuation in the hormones. Yes.
You know what? That's what I love about you. Like, you're a surgeon, and at the same time, like, you see it on both sides. And like this connection between, I mean, very few people are able to answer that question, right? Most people tell you, oh, it doesn't affect anything. I mean, the ovaries are, that's where the hormones are. But then when you start linking your surgical skills and expertise from blood supply to that, and you're like, and that's, I think, where you're pushing the envelope to the next level. And that's where you're like, very few people have so much knowledge on the surgical part, and so much knowledge on the hormonal part, and so much knowledge on the lifestyle part, and connecting all these dots together.
I used to think like that, Dr. Salameh, that, the ovaries have their own blood supply, and I'm taking out the uterus and tubes only. And I've had some patients who are in their mid-40s come in for their 6 weeks follow-up, and they're like, Doc, I'm having hot flashes. And I'm like, that doesn't make any sense. But when, obviously these patients know me and trust me, they tell me what they feel, and I don't take that lightly. I've had a few of them, complain about that. And obviously the recent, I'm not sure if it's a meta-analysis or something that looked at that. And I would look it up and I will share it with you. But it does compromise the blood flow to the ovaries.
I
Not
love
sure
it.
if that's transitory, and then they would they compensate later, because the majority of them, have that, spike of, like, I'm having hot flashes, and then they come a month or two later and it's gone. So it could be like a temporary shock. It's worthwhile doing some further investigation, doing some studies, looking at some hormonal levels before hysterectomy, after hysterectomy, with ovarian conservation, and see if there's actual physical quantification of that.
I love it. And you know what I love the most about it is you actually listen to the patient. And not only listened, you listened and believed her. What happens in the medical field, when patients talk to us, we're just not listening. Or we might look like we're listening, and if we're listening, we might not be believing. And that's like a huge thing. Just listening and believing to our lipedema patient, like that's how we're discovering things because they are right. Like 99.99% they are right. And I think you're right, and I think your patient is right on this one. Like probably in 10 years they're gonna figure that out when you do hysterectomy without oophorectomy, and that is probably a shock and this and that, and maybe you might recover 10% or 80%, whatever that
Yeah.
data is gonna show. But there is a link. Of course there is a link. I mean, she's living it, she's experiencing it. You just took the time and you believed her.
Yeah, 100%.
Man, that makes so much sense. I love it. I love it. Let's take. I know, man, you have patients to see, and let's take this last question here, and then kind of we'll wrap up. Brand is asking. I had a partial hysterectomy in my early 30s, and I'm now in menopause and on HRT. My doctor just added progesterone to my daily regimen. Any thoughts on that?
Agree with your doctor 100%.
That's awesome.
Yeah, he's doing the right thing. Obviously, we've always thought that progesterone only works in the uterus, because if somebody has a uterus and they're getting hormone replacement with estradiol, they need to take progesterone to kind of counteract that effect on the uterus and prevent cancer. So we've always thought that if somebody has had a hysterectomy, just give them estradiol. They don't need to take progesterone. But her doctor is giving her cyclic progesterone. He's trying to mimic exactly what she used to have when she was in her 20s and 30s. So he's basically trying to get her back 20 years back. So that's genius. I think that's genius. That's the right thing to do. He's living ahead. And that's what I personally do for my patients who have had the hysterectomy. I cycle them. I give them 2 weeks on, 2 weeks off. Progesterone, low dose. It has effects on their sleep pattern, their cognition, their anxiety levels. It's a hormone. It's going to have to work somewhere. So when it goes down, in my opinion, should be replaced.
That's awesome. I love that. We have Dr. Labib here. He's gonna giving us like good vibes. Just for our audience, I know you guys have an amazing podcast together. If you wanna like direct our audience there so that they can check it out if they need more information about that.
We do. Hi, Labib. Thank you for the join. So we do have we co-host a podcast, Labib and I. It's called Reframe Your Health. People can find it on my Instagram page. So we basically look at topics in women's health. We look at the topics from a variety of angles, from a functional medicine standpoint, from a traditional medicine standpoint. We try to bridge the gap. We try to see what's out there that's new. We're soon gonna bring in things from the biohacking world, whether it's gonna be in women's health in general, or and pregnancy as well. Labib is a maternal fetal medicine specialist who also does functional medicine. So, he's a great friend, a great mentor who on a daily basis opens up so many things in my head and keeps me want to think forward. So if somebody wants to join our podcast, it's called Reframe Your Health.
I love it. Doc, I appreciate you. It's been beyond an hour, and I know you got a fully packed this afternoon. Thank you for your time, and thank you for all the knowledge. I personally learn a lot every time I go on live with you.
Thank you so much for having me. I appreciate everybody being here, their questions, their interest in seeing us. Anybody has anything else that they want us to research, answer, if they heard something that they have a question about, please let us know. We will happily answer, come back again in the future. Thank you, Bernard, for having me again. You're awesome. Your patients are lucky to have you. I'm lucky to be with you here. And, enjoy your afternoon.
You too. I love it. Thank you, guys. Thanks for everyone. And I'm sure we'll probably have a 3.0 session. I didn't get through all my questions, so I probably need a session just for myself. Awesome. All right,
All
guys.
right.
Thanks a lot. Have a good one.
Ciao. Bye.